Good morning, all. I am Dr. Lavesh Agarwal, Associate Professor, Index Medical College in the Orthopedic Department. Today, my topic about total knee replacement, arthroplasty. So, we can discuss arthroplasty one by one as a overview, anatomy, anesthetizers, procedures, and lastly, that's about management. So, first of all, overview about arthroplasty, anatomy of knee joint, common conditions leading to total knee arthroplasty, evaluation of TKR, total knee replacement, and our own data. So first of all, we discuss about the anatomy of knee joint. We all know our knee joint made up of three bones: femur, tibia, and patella. So upper thigh bone is known as a femur, leg bone is tibia, and cap is patella. So three bones and three compartment which is involved in osteoarthritis, that is known as three compartmental osteoarthritis, and ultimately goes for solution as a TKR. So knee stabilizers. Knee stabilizers means knee can stabilize via medial structures, lateral structures, anterior, posterior, and rotatory. Anterior structures include ACL, posterior structures include PCL, posterior cruciate ligament, medial collateral, lateral collateral. So all are knee stabilizers. As we can see in these pictures, adduction, abduction, flexion, extension, and rotation. These are the knee stabilizers. Common conditions that leads to TKR, osteoarthritis, primary and maybe secondary, such as post-traumatic arthritis, and systemic cause is rheumatoid arthritis. Knee arthritis means osteoarthritis, more common than hip osteoarthritis in Asian population. Age 80% above 70 or 75. Sexually equal in both sex up to the 45 to 55 years. After 55, more common in female. Risk factor of osteoarthritis. Definitely increasing age in senior citizen patients. Osteoarthritis may lead to advanced stage. Obesity is a precipitating factors. Female more commonly involved after 55 or 60 years. Trauma is a predisposing factor for osteoarthritis. Obviously, infection, chronic osteomyelitis, septic arthritis may be a cause of osteoarthritis. Repetitive occupational trauma. So all are risk factor which leads to osteoarthritis start from initial stage. to advanced osteoarthritis. Clinical features of osteoarthritis means depend on the stage of involvement. We can see pain around the knee, especially in OA knee, swelling, stiffness, deformity is there, means FFD, fixed flexion deformity, loss of functions, less mobility, and we can found also crepitus. So the most common clinical feature is a pain. Second one is swelling. Third one is stiffness, deformity, loss of function. The patient came in OPD with pain, swelling, redness. So all are features of osteoarthritis. This is a radiological picture. In normal X-ray, there is a space between the femur and tibia in which meniscus and cartilage are persist. But in osteoarthritis, sorry, there is reduced gap in joint space. So you can see in X-ray, there is a reduced gap in femur and tibia. In lateral picture, patellofemoral arthritis is seen, no gap between the femur and tibia. So AP standing view is the most specific view in osteoarthritis, and lateral view give information about your patellofemoral arthritis. So tibiofemoral arthritis and patellofemoral arthritis both are involved in osteoarthritis. When we come about management, so there are non-operative management and operative management. Non-operative management means before go for surgery, you have to treat pharmacological, non-pharmacological, physiotherapy, all are therapy which can avoid surgical intervention. Means non-operative, non-pharmacological. Non-operative, non-pharmacological means initial stage of osteoarthritis. So we can educate patient use of assisted device, weight loss if patient is a heavy weight. So we can educate weight loss training program, physical therapy, occupational therapy, all are non-pharmacological therapy in stage 1. Between the stage 1 and stage 2, we treat with the pharmacological therapy with NSAIDs. Most effective therapy is glucosamine sulfate, Ondatin sulfate, glucosamine sulfate regularly give in osteoarthritis patient in initial stage more than 1 month or 2 months, at least 3 weeks, minimum 3 weeks. So we can found better result Intra-articular corticosteroid, intra-articular hyaluronic acid. So all these are non-operative management. Now come on operative treatment. So operative treatment may be a orthoscopy, orthoscopic deployment in large. Second one is osteotomy in early stage of young patient below 40, 45, which cannot perform surgery in early stage. So osteotomy is a good option below 40 or below 50 years of patient. And last one is knee replacement surgery. When initial stage in patient came with symptoms of osteoarthritis stage 1 or stage 2, so we can evaluate the patient, do MRI, X-ray. If finding in favor of orthoscopic debridement, so we can do orthoscopic debridement. Orthoscopic debridement with the help of orthoscopy, there is a lavage, partial meniscectomy can be done with or without, and proper thoroughly debridement and orthoscopy can be done. Osteotomy. Osteotomy, which is a alignment, femur and tibia axis. So which from tibia is removed and osteotomy plate, fixed by osteotomy plate, and can alignment can be done and below 40 or below 50 years. This is a very good option, or replacement can be avoided in early stage of patient. Now, knee replacement. Knee replacement can be can we do in a two proper way: partial knee replacement and total knee replacement. Partial knee replacement can only be done in when medial compartment is involved. Only one compartment is involved, that is known as a medial osteoarthritis. So particular indicated in medial compartment. But when tricompartmental osteoarthritis is there, medial, lateral, and posterior compartment is involved. So the only option is total knee replacement. So in early stage, when medial compartment is involved, then only can we do partial knee replacement. When tricompartmental osteoarthritis is there, so have to do total knee replacement. Evolution of TKR. In 1940s, first artificial implant were tried when mold was fit in femoral condyle. In 1950, combined femoral and tibial articular surface replacement appeared as a simple hinge. John Stahl, 1973, designed what has become the prototype for current total knee replacement. This was a prosthesis made of three components which would replace all three surfaces of the knee, means femur, tibia, and patella. So all three components, when replaced, first time designed as a joint installed in 1973. When we are talking about implant, so implant can be a unconstrained or constrained knee. Unconstrained knee means crucial CR, crucial retaining, crucial substituting, mobile bearing, and hinge one. Unconcentrated TKR means there is no hinge between the joint. Constrained knee, there is a hinge between the femoral component or tibial component. There is a locking system. This is unicondylar TKR, already previously discussed in medial osteoarthritis. So medial component is involved, then you can do unicondylar TKR. So the replacement done only a medial condyle. Total knee replacement today. Large variety is available today. In today's scenario, majority of TKR condylar replacement, which consists of following: cobalt chrome femoral component, cobalt chrome tibia, UHMWP tibial bearing component, and polyethylene highly cross-linked polyethylene for insert and patella component. Who is a good candidate for TKR? Quality of life severely affected when a patient come in your OPD. The patient complaining severely affected quality of life, pain, swelling, redness, not able to walk properly, not able to climbing stairs. So is most indicated patient for TKR. Daily pain patient are suffering from routinely pain 24 into 7, or at least pain in general walking, climbing stairs, sitting, in any activity. If he or she sustaining pain, so is a good candidate for TKR. Restriction of ordinary activity means walking, climbing stairs, sitting. The patient, if restricted all our activity, and evidence of significant radiological change of knee. When we prescribe AP standing view and lateral view of knee joint, and findings is severely affected OA knee, means joint gap is reduced in joint. So is a good candidate for TKR. What is the time of replacement? Old age with more sedentary lifestyle, above 40 or above 50. This is most confusing factor in replacement because implant has a own life. So 40 to 50 years old male female, what can be done? So managed by the osteotomy if she can or if he can. And if above 55 or 60 old age, so ideal time for replacement. Young patient, but who have limited functions, progressive deformity can be checked by progressive X-ray time to time. Other treatment modality have failed. Non-pharmacological and pharmacological treatment have already failed. So is a good candidate for replacement. PKR should be done before things get out of hand and patient experience is a severe decrease in range of motion, deformity, contractures, joint stability, or muscle atrophy. So always advise TKR in a patient which severely decrease in range of motion. If you find FFD means fixed flexion deformity, joint instability, or muscle atrophy. Evaluation of patient before surgery. As a standard protocol, a complete medical history should be taken in a proper manner. Thorough physical examination, clinical examination, evaluation of knee, particular joint, and associated joint. You always check spine and hip joint or rule out any other associated deformity or precipitating factor. Many times, patient complaining of knee pain just because of radiculopathy of spine. So you should examine spine first and rule out the spinal pathology, numbness, radiculopathy. When you assure the pain is just because of a knee or osteoarthritis, this is the only candidate for TKR. Laboratory workup, yes, 100%. You should check all parameters related to surgery, means CBC, hemoglobin, sugar, count, LFT, serum protein, electrolytes, and standard protocol, HPSAG, HIV. And if a patient has a history of any medical pathology, means diabetic, blood pressure, thyroid, so you should check always blood sugar level, thyroid level, and other levels. Anesthesia assessment, PAC should be done pre-anesthetic checkup. Recommended pre-operative radiograph in knee replacement surgery, standing full length AP view, hip to ankle, lateral knee X-ray. So AP standing view of knee joint is mandatory. Lateral knee X-ray give your additional information about your pathology or your joint deformity or your patella arthritis, patellofemoral arthritis. So always should do lateral knee X-ray and marching. Goal of TKR, pain relief, restoration of normal limb alignment, restoration of functional range of motion. Successful results depend upon successful result depend upon precise surgical technique, sound implant design, appropriate material, and patient compliance with rehabilitation. Technical goal of knee replacement surgery: restoration of mechanical alignment, preservation of joint line, maintaining of restoration normal Q angle, mechanical alignment, total knee orthoplasty, aim at restoring the mechanical axis of lower limb by sequential soft tissue release, correction of bone defect by graft or prosthetic augment. Mechanical axis, we draw a line from ASIS to center of hip, center of knee joint, and second toe. So this is a mechanical axis. Yes, when we draw a line from ASIS, center of hip, center of knee joint, and second toe of foot. So this is, you should always check mechanical alignment. Now, outcome depend your surgical skill, which include ligament balancing, coronal plane, sagittal plane. Coronal plane, varus deformity, the most common deformity in ONE and valgus deformity. Sagittal planes, flexion contractures and extension contractures. Procedures. End of femur remove. End of femurs means cartilage surface, articular surface of femur, which is already damaged. It's removed. Same in manner. articular surface of tibia or damaged part of tibia is removed, which is known as a 9 mm. 9 mm or most probably 10 mm. Back of patella also removed, and femoral implant after cutting all distal cut and all cut has been done. Then after you should insert your implant one by one as in a manner femoral component and tibial component. Tibial component insert, femoral component insert, and in between these space there is an insert polyethylene, highly cross-linked polyethylene. So patellar implant also inserted. There is a two category of surgeon, non-patella replacement surgeon and patella replacement surgeon. So when patella is indicated means old fracture of patella, chronic arthritis of patella is severely damaged, or any predisposing factor of trauma, then patella can be replaced. Otherwise, you can replace femur, tibia only, and patelloplasty done. So this is complete procedure. In this picture, this is the post of cinematic picture in which femoral component, tibial component, and patella component may be seen. This is the surgical technique. There is a midline parapatellar approach can be taken. You start your knife with superpole of patella in a midline manner up to the tibial tuberosity as your comfortability. This is the picture in which muscle retract, all joint cut can be taken, inserted the implant. This is after inserting the implant and before closing the joint. This is a surgical intra-op picture. This is suture line. You can see midline parapatellar approach. When you can start your midline parapatellar approach, you just subcutaneous dissection, medial and posterior release, then expose of joint. You can all cut with the help of jig, anterior cut, distal cut, posterior cut, chamfer cut, and tibial cut also. So all cut already taken, then cementing humeral component in tibial component. Then you insert the implant. So this was the picture inserting the implant, and this is just after your closure. Now post op rehab. Post op rehab after knee replacement surgery. Post op rehab has a big role to mobilize the patient. Rapid post-operative mobilization, range of motion exercise is started, CPM, passive extension by placing claw underfoot, flexion by dangling the leg over the side of bed, muscle strengthening exercise. Weight bearing is allowed on the first post-op day. So if you are confident your surgery, your fixation, your implant technique, and your surgical skill, so your patient can walk on next day, very next day. But when you are inserting a implant which is indicated in a over the 50 or 56 or above 50, then it is knee replacement is a good option. But when a patient come below 50, so were you must confuse, there is an option of osteotomy or knee replacement when the patient come under 40 or under 50. So I think there is a good option as a osteotomy, avoid TKR. But when patient come above 50, severe osteoarthritis, compartmental involvement, so a good option or good candidate for TKR. Now, last point about the prosthetic survival. As a Dr. Ranawat, 95% at the 15 years and 91% survival rate at 21 years. Gill and Joshi, according to Gill and Joshi, 96% survival at 15 years and 82% at 23 years. This is a data according to Ranawat Sahab and Gill and Joshi. So this is all about your knee replacement surgery, surgical technique, anatomy, overview, pathology, stabilizing, investigation, surgical technique, rehab protocol, about your prosthesis, and all other things which can induce the complication. So always keep in mind post-op complication about your TKR. The most common complication is infection. Obviously, when I put a artificial implant and we open the joint, so there is always a chances of infection. So to avoid your infection, post-op infection, you should always check your pre-operative planning, pre-operative lab criteria, and pre-operative thoroughly clinical examination to examine your skin around your operative site, any other medical history, any other history of steroid taken by a patient. So you should always rule out the factors which initiate or which precipitate your post-op complications. After knee replacement surgery, you should move your patient as early as possible. And most dangerous part is DVT, deep vein thrombosis. Because this is a major surgery, so we always should conscious about your deep vein thrombosis. Always prescribe some blood thinners to avoid deep vein thrombosis. Do try a early mobilization of patient, and you should educate your patient about your rehab, ankle pump, and some other exercise which can do in a easily manner without help of any physiotherapist. So this is all are the factor about the knee replacement. Thank you so much. I'm finishing my topic at this point only. Thank you.